Welcome to everybody that's joining our webinar. We will be starting here in about 5 minutes time. I'd like to thank all 1,000 of you that have registered. Thanks for your support of the Washington Academy of General Dentistry's Stay Home, Stay Healthy CE webinar series. We've got a great presentation coming up today by Dr. Yassin. He's doing a ton of work for us at the Washington Academy of General Dentistry. He's got a master track presentation. He's got a hands-on implant course that'll be starting up again once we get past this pandemic. For those of you that haven't joined us on a webinar before, these webinars are being sponsored by the Washington Academy of General Dentistry, the Canadian Academy of Restorative Dentistry and Prosthodontics, the Snohomish Dental Society, the Pierce County Dental Society, Seattle King County Dental Society, the University of Washington Continuing Education is one of our big sponsors, Comet USA and Patterson Dental are our sponsors. Dr. Yassin also has some sponsors that support him in his lecture series and his WAGD courses, implant courses. After Dr. Yassin's presentation today at 3 o'clock, we have Dr. Ralph Schuler that will be presenting on multiple implants in the aesthetic zone, expanding your options. So this afternoon, you're probably going to be able to get 2 or 3 hours of CE from just sitting there at your home. And again, we thank you for joining us. Regarding CE, anybody is welcome to attend these webinars. Any dentist, you do not need to be an AGD member. We appreciate those of you that are AGD members. It's a great organization that's really focused on continuing education of dentists right from the first day they enter dental school to the day they hand over the keys of their practice. Regarding CE, you will be getting a CE verification in your email at the email address you registered for to attend this webinar today. For those of you that are AGD members, we will be submitting your CE credit directly to the AGD, but please do not be looking for that right away. It's going to probably take 2 to 4 weeks. There's just a major backup with the AGD with recording CE credit right now, obviously with all the webinars that are coming up. We would invite you to continue to go to the Washington Academy of General Dentistry .org homepage to see upcoming CE webinars that we have. We're adding them as quick as we can. Hey, you know, and we want to just thank all our speakers that are volunteering their time to do these CE events. Not a single one of the speakers for the WAGD Stay Home, Stay Healthy CE series are receiving an honorarium whatsoever. So we appreciate the volunteering of these people, of their time and their expertise and their presentations. It's now 1 o'clock. We'll look and see. Good. Everybody's seems to be getting logged on. We'll give people just a couple more minutes here as you watch the flyers for upcoming webinars come through here. Again, I just want to thank our sponsors, the Washington Academy of General Dentistry, the University of Washington School of Dentistry AGD Student Chapter, probably considered the premier student chapter in North America. I'm a little biased. I'm the liaison to that chapter. So thanks for all our students that are joining us. The University of Washington School of Dentistry, CE. Thank you, Sally and Joy. Comet USA, appreciate your support for helping put these webinars on. The Canadian Academy of Restorative Dentistry and Prosthodontics. Thanks for handling everything on your side there, David. Appreciate it. We'd like to thank the Seattle King County Dental Society, the Pierce County Dental Society, and the Snohomish County Dental Society, along with Patterson Dental for supporting today's presentation. This afternoon's presentation is Dr. Alan Yassin, Dental Implants, Delayed Complications and Peri-Implantitis, Diagnosis and Management. Dr. Yassin, you know this is a favorite topic of mine, and so we're looking forward to your presentation. I'm just going to run through the CE information one more time. For those of you that have registered, that are AGD members, we will be reporting your CE credits directly to the Academy of General Dentistry. You do not need to do that. For those of you that are not AGD members, you will be receiving verification in your email within the next couple of days of your participation in this webinar today. We'd like to encourage all of you to visit our website, thewashingtonagd.org, to see upcoming webinars. We've got another 15 or so scheduled right now, and I've got 3 or 4 more speakers that we're getting queued up. So we'll be having CE webinars for probably the next 3 weeks. It'll vary from 2 to 3 a day, depending on our other commitments at the Washington Academy of General Dentistry. If for some reason you miss part of this webinar, or you want to show it to a colleague, you can visit us on YouTube. These presentations will be up probably within the next day or so, and those are at YouTube, Washington Academy of General Dentistry. Dr. Yassin, it looks like it's about 5 minutes past the hour. I'm going to stop sharing my screen, and I'd like to welcome you, sir. And
okay,
you are live.
Thank you, Dr. Hess. Let me make sure that my screen is shared here. Okay, are we good to go?
We're good to go. Thank you.
Perfect. Awesome. Thank you so much, Dr. Hess, for all this great introduction, the great work you've been doing for this, for the dental community, and for not only in Washington and the States, but probably all over the world right now. Welcome everybody to my webinar today, Dental Implants, Delayed Complications and Peri-Implantitis, Diagnosis and Management. We're gonna spend some time talking about this topic. I know it's a big topic, so I'm gonna try to summarize it as much as I can, break it down into some simple discussion areas. I am Alan Yassin. I am a dentist. I am a dual trained dentist in periodontist and oral surgery. I practice here in Seattle, Washington, and I'm an affiliate faculty here at the University of Washington as well. I wanted to just spend a minute just to mention all this great work that everybody is doing at the Washington Academy of General Dentistry, University of Washington School of Dentistry. Dr. Hess, Valerie, Dr. Hayamoto, everybody at the dental community here, from Snohomish King County to Seattle King County, they're putting a great presentations and webinars at the Stay Home, Stay Healthy program. Great speakers. I've been watching most of the webinars, so I'm encouraging everybody to join this great opportunity. For me, I'm participating with an implant study club. It's a weekly meeting, online webinar meeting. It's really a great opportunity to have this clinical discussion. The first one is going to be coming this Friday, April the 17th, 12 p.m. Seattle time, Pacific time. So please feel free to share this opportunity with everybody. I'm going to have some guests with me on this Friday. I am going to have Dr. Hassan Magaira, the president of the British Academy of Implant and Restorative Dentistry. So please feel free to join us, guys. I would just spend some time to mention a great efforts that we've been doing here at the Washington Academy of General Dentistry. Dr. Hess mentioned this clinical implantology A to Z. It's a great program that we do live surgeries and hands-on courses. And please take a moment to take a look at it, and I'm more than happy to answer any question regarding this. Let's go back to our topic, the complications, delayed complications in implant dentistry. You know, this is a really big topic. So when I was starting to prepare this presentation, I faced my 2 days implant complication course that I usually give in 2 or 3 days. And instead of just going into the whole complications in implant dentistry in general, I decided just to break it down into more for delayed complications, restorative complications, and peri-implantitis. So today I'm going to spend some time before talking about the complications, just to review some of the treatment planning concepts to make sure that we understand that we need to avoid any complications. So solid treatment planning will lead us to avoid any of this complications down the line. I'm going to discuss some post-operative delayed complications. We're going to discuss restorative complications after receiving the prosthesis. We're going to spend some time talking about peri-implantitis, and finally the implant failure and removal. When we have complications, we have some causes for the complications. Doctors are responsible for their cases, for their implants, and their treatment planning, surgical skills, restorative skills, training and knowledge, anatomy, knowing the surgical basic skills. Patients are also responsible for the services that they receive with implants. The motivation from patient, the compliance, the hygiene, the instructions following, the follow-up, the cooperation, and of course, the choice of the dental implant system and the lab technician is really important for us to build a solid treatment planning and treatment. One of the most important messages in implant dentistry is when we have to start implants cases from the ideal final prosthesis aimed backward, meaning that we need to understand where are we going with the final restoration before we are planning to do any surgeries or any treatment planning or any methods there. The comprehensive treatment planning is absolutely the key for the success. After any comprehensive treatment planning, we must know several points, and I'm going to go through this one by one. We must understand in each dental case if we need any soft tissue or hard tissue management before doing the surgery or simultaneously when we do any surgery. We need to understand if we need any special advanced surgical techniques, the sinus lifting, sinus floor augmentation, expansion, ridge expansion, or ridge splitting. Understand the bone quality and the quantity. Know the surgical plan, and whoever attends my courses, they know that basic surgical skills is a big portion of my teaching aspects, just to make sure that we know how to deal with basic incision and flap design and flap reflections. We need to understand what's the implant shapes, design, and types, implants location, measurements, number of the fixture we're using, implant position in regard to the bone level. Are we putting this on the bone level, subcrestal, supracrestal, at the tissue level? The implant loading, are we going to do immediate loading, delayed loading? Are we going to do the surgery in 1 stage or 2 stages? What are the abutments and the connections that we are using? What's the temporization portion that we're doing? What's the final prosthesis, which is one of the things that we're going to spend some time today to talk about. And of course, the estimated time and estimated cost for our patients. So again, the message before talking about any complications, we need to remind ourselves with this basic dental implant messages. Prosthetic treatment planning is the case to avoid any complications. Interdisciplinary approach to have a big team between surgeon, between general dentist, restorative dentist, prosthodontist, periodontist, oral surgeon. Everybody gets together just to make sure we have a good study for any case and we provide our patients with the best services possible. One of the things that we need to know for prosthetic treatment planning, that we both have this old style of getting our models and study our cases, or we can do digital. For this case, and for example, complicated case, we have a lot of missing teeth, failing implants, we have failing teeth, we have some kind of old restoration, periodontal infection, perio-endo lesions. So in general, we can just simply take our models, make sure we have great models, and go ahead and design our final restorations on the lab, right? Just to do some wax up, set up, make sure that we're having the right study for the case before even we proceed with discussing the final treatment with either the patient or with our team. It's really important for us to consider other specialties if we want to do any orthodontics treatment, if we're going to get a prosthodontist involved. So wax up and a setup on a regular models, it's really important step for us to avoid any of possible complications down the line. Utilizing the technology available is important. The three-dimensional CT scan is really a great tool in implant dentistry, and I almost do this CT scan for almost all my cases in implant dentistry to understand not only the bone quality and quantity, but also to understand the final restoration position and where are we planning to place our implant in position and locations. I know that we have different levels attending. I heard that there's almost 1,000 of doctors from all over the world attending. So I know we have either advanced levels in implant dentistry and some beginners, some dental students, usually they attend. So I wanted just to go over the CT scan and really quick to touch base with what we have here. And the three-dimensional CT scan is a great tool to provide us with mainly three cuts. The one cut here on the upper left, it's the axial cut that will show us as if we're looking from the top or from the bottom. This panoramic cut, it's a frontal, so as if we're taking a look from the front. And the other cut here is the sagittal cut that will give us the look, more information about what we have in buccal lingual and for the bone available in the apico-coronal position as well. So it's a great tool. We can have a lot of information from the CT scan. I can't imagine a lot of dental implant cases nowadays in 2020 without really going through this three-dimensional CT scan studies that also not only will help us with the old traditional way of studying dental implant cases, but also with the new way of doing the digital implant dentistry cases that will help us save our time and give us more accurate treatment planning for our cases. We will be able at the digital implant dentistry steps to get not only the CT scan, but we can also plan virtual implant placement into the bone that will provide us with more information to know exactly where is the final restoration will be located, what is the design of the final restoration, and exactly what's the implant placement inside the bone. The digital implant dentistry will require also either models and scanning the models or intraoral scanning, along with the CBCT scan that we can merge or superimpose together to make sure that we are transferring to this software that will help us with the starting with the restoration design and go back and do the implant virtually at the correct position, know exactly what's the bone available, what's the vital structures around the area, and make sure that we are planning our case correctly. Again, we start with the final restoration, the ideal final restoration in any case, and we go back to our implant placement to decide if there's any need for augmentation or any special need before we do the implant itself. Well, one of the things that I always been asked about is what about the surgical guides. The digital implant dentistry is a way for us to help us planning our restoration and implant placement correctly. Surgical guides is one of the tools we have in our back pocket to help us with that. After planning our final restorations and our implant placement, we can print out the surgical guide that will help us to place our implants, not only place our implant, to drill inside the bone, place our implant in three-dimensionally acceptable position for the final restoration. And as you can see, we have a lot of different designs for the surgical guide. It takes a lot of steps to fabricate this surgical guide. One of the messages that I always share with everybody, that even if it is computer-guided surgery with the surgical guides, but it should be a brain-guided surgery, because we need to spend some time making sure that the surgical guides, it's a good fit. We don't have any errors through the steps before fabricating this guide. Talking about all this stuff, and before even jumping into some complications in implant dentistry, I wanted to just remind ourselves some of the basic knowledge in implant dentistry about the prosthetic design. And the final restorations has different classifications. I chose to share with everybody. This classification came from Mish back in the 1990s. Dr. Mish divided the prosthetic over implants into two big categories: the fixed prosthesis, FP, the removable prosthesis, RP, and with 5 categories. The FP1, with the prosthetic crown, will only replace the natural crown. The aesthetic is similar to the natural tooth. Simple, straightforward cases. We don't have a lot of need for bone and soft tissue augmentation. FP2 is when the prosthetic crown replaces the natural crown plus a part of the root. So we'll be needing either to do a little bit more of augmentation, or to make sure that we have some kind of restorative materials like pink ceramic or whatever available to restore not only the tooth but also part of the root as well. FP3, the prosthetic crown replaces the missing crown, the gingiva, as well as part of the atrophic alveolar ridge. So we have a little bit more advanced atrophy going on in the hard and soft tissue, and we need just to make up with a better prosthetic to cover a bigger portion of this gingiva and bone as well. The RP4, removable prosthesis, where the fixed detachable prosthesis is completely supported and retained by dental implants. This is what we call the hybrid restoration. It is fixed, but it is detachable by the dentist. And finally, the RP5 is the removable prosthesis, whereas the over prosthesis is supported by soft tissue and retained by dental implants, either by locators or bars over the restoration. So this is one of the very simple classifications. I wanted to mention this because this is the goal. Before even we jump into doing the surgery or the implants, we need to understand where are we going before we placing our implant. One of the cases that I always share with my presentations is this one, where the dentist placed more than needed implants, 4 implants to restore the mandibular anterior area. And at the end, he ended up with not enough space to restore the implant, so he put 1 implant down sleep. All this, whatever we discussed for restorative treatment planning before doing the surgery, is the best way to go to avoid those kind of situations, and to know exactly our final restoration. Either we're going to do individual crowns, bridges, or even some fixed detachable restoration. And again, before we doing any surgery, we need to remember this, what the master taught us back in the 1980s, when the first implant literature started to get more mature. Brenmark, he taught us 3 main concepts to when we do the implant surgery. We need to make sure that we have enough bone to implant contact when we place our implants. We need to make sure that we have enough initial stability, and we need to place our implants in the most ideal restorable position. When we put our implants, touching some of the basic numbers also to make sure that we are not over treating our cases, we need to put our place our implants and positions with good diameter of the implant. We don't really need to exceed the minimum diameter that that is shown. And we have a lot of suggestions. Mandibular incisors, we don't really need to go over 2.5 to 3 millimeter. Mandibular canines, 3.5 to 4.5 millimeter. Maxillary laterals, 3.0 to 3.5 millimeter. Maxillary centrals, somewhere between 3.5 to 4 millimeter. Maxillary canines, it's 4.0 to 4.5 millimeter. Premolars in general, 4 to 4.5. And the molars in the back, we can go anywhere between 4 to 7 millimeter, depending on the available ridge. So this is important for us because a lot of time I see either by cases sharing over the social media or going around the internet that people are trying to augment the bone for more bone needed than what we want to put the implant in. For example, if we're going to put an implant in the maxillary lateral area, and all what we need is a 3.5 millimeter implant, there is no need to do extra bone building because all what we need is 3.5 millimeter of implant diameter, 2 millimeter in the buccal, 2 millimeter in the lingual, and we will end up with almost 7 to 8 millimeter of bone ridge. This will bring me back to also share with the basic numbers with when we put our implants. We need to remember the basic literature that's in the implant dentistry to put the implant with almost 1.5 at least millimeter away from the natural tooth and 3 millimeter between two titanium implants to make sure we have good space for them and the bone to be vital in the area. As for the apical coronal position, we need to place our implant deep enough and as shallow as possible. So we want to put the implant between 3 to 4 millimeter more apical to the CEJ, to the tooth next door. If we don't have a dentition adjacent to this implant, we place our implant around 3 millimeter apical to the gingival margin. And it's really important for this apical coronal position to know exactly where are we going to put our implant platform, which is the final connection between the implant and the abutment as well. If we're going to put the implant in the more short position, a more shallow position, we'll get more short restoration, and we're going to have problem with the emergence profile, which we're going to be discussing down the line. If we put the implant deeper, we're going to end up with a problem with the implant to restoration ratio, as well as the emergence profile as well. And with the labiopalatal position, buccal lingual position, we need at least 2 millimeter around the implant bone and natural bone to support the implant and make sure we are in a great position to have the implant supported. And finally, one of the small things that we need to remember before placing the implant is the restorative space. And we have different, as you could see from the classification, mesh classification that I shared. In general, if we are doing fixed restoration, either crowns or bridges, we need around 9 millimeter in the restorative space for the porcelain crown, for cemented retained, but when we have screw retained crowns, probably will go down to 6 millimeter, which will be more than enough for us. I know there are some hygienists joining us from Snohomish King County Dental Society, so I wanted just to share some of this basic stuff with them to know exactly the fixture inside the bone, and know that the abutments, they are getting into the connection at the platform level of the implant. Nowadays, we prefer to have this platform switching where the abutments will get a little bit smaller than the diameter of the implant. 9 millimeter is enough for us to have the restoration of cement retained restoration. Hygienist is really a good, important element in our dental practice and dental implant practice, because they take care of the implants after restoration. And we're going to spend more time to know exactly how to deal with this connection here when we do our maintenance for our implants. How long is the connection between the abutment and the soft tissue around it? What's the collar thickness? That will lead us to better cleaning and better keeping this oral hygiene on top of the implant placement. So with the dental implant in general, we need to make sure we have all this protocol that I follow before performing the implant surgery, just to do an initial consultation. There is absolutely no need for us to jump directly into implant surgery. From the first time. I don't really do surgeries on strangers. I need to make sure that the patient is well educated about the concept and they know exactly what are we going, collect all the clinical data, impressions, photos, 2- and 3-dimensional radiographs, doing the diagnostic either by digital side, wax up, set up, regular analog way, order the radiographic stents. We can do the CT scan, 3-dimensional CT scan with the radiographic guide in place if we want to go with the regular traditional way of doing our surgical guide. Analyze the data, develop treatment plan, make case presentation to a patient. I call it pre-surgical appointment, where I meet with the patient before the surgery, discuss, finalize all the cases, know exactly what is the timeline, what's the cost, what's the consent forms, know exactly what's the anxiety level of the patient. If I want to do my surgeries under sedation, kind of IV sedation, oral sedation, will be ready before we doing the surgery. So this is just an introduction. I wanted to share this with everyone so we can have a basic mutual base to try to avoid any of the possible complications. Usually when I teach dental implants complications, as I said at the beginning, it takes probably 1 to 2 days course to discuss the complications, and still I can't really cover everything. The complications in general, they are divided into intraoperative surgical complications, post-operative early complications, post-operative delayed complications, restorative complications, and peri-implantitis. In this presentation, I'm gonna discuss mainly the post-operative delayed complications and the restorative complications, plus the peri-implantitis. Probably we'll find time down the line to discuss the intraoperative surgical complications and the early complications after the surgeries. But also, even with the post-operative delayed complications today, it's really huge. So I'm going to try to summarize as much as we can. We're going to find some time for questions and answers at the end. I have a block of around 2 hours for my presentation. So now we're going to start discuss the complications. Feel free to ask your questions. At the end of the presentation, I'm gonna go back and do some answering for your questions. Post-operative delayed complications, I broke it down into 8. Of course, there are way more than this, but soft tissue inflammation, hyperplastic gingivitis, maxillary sinusitis, bone resorption, chronic pain, implant mobility at the time of the second stage surgery, healing abutments loosening, bone growth over the cover screw. Let's start with the soft tissue inflammation. It's I'm talking here about what we call it the peri-implant mucositis, where we have a reversible inflammation reaction for the mucosa around the implant. There will be no bone loss, so we're going to have some kind of inflammation going on. The peri-implantitis process, as we're going to discuss down the line, will include some bone loss, while in this peri-mucositis, which is very common to see, is caused by bacterial causes. We have different plaque and calculus accumulation into the area, both anaerobic gram-negative and anaerobic bacteria, will really go into the cause for doing the peri-implant mucositis. The good thing that it's reversible, so a lot of time either the bacterial cause or the mechanical causes for the peri-mucositis, either by food impaction, prosthesis, suprastructure is not really adapted, patient oral habits, and patient dietary habits. One of the main things we need to pay attention for our peri-implant mucositis is early diagnosis, establish a good oral hygiene with our patients, ideal restoration contour, and discuss treatments with either the oral hygiene instructions or some minimum surgeries with apically positioned flap surgery. I went back to the literature to see exactly what we have on board. We have different studies to discuss the peri-implant mucositis, which is one of the biggest complications we see in implants. We have the plastic curettes usually, it's really beneficial, and you know, conventional maintenance is really beneficial into providing treatment and avoiding the peri-implant mucositis. Schenk and Frajo, they found the chlorhexidine irrigation and local tetracycline is not effective in the peri-implant mucositis. We have different debatable ideas in the literature about the treatment, but here we can summarize what we can do in the treatment. When we have advanced peri-implant mucositis, one of the cases we have is to try to go surgical treatment by apically positioned flap, mainly to make more access for patients, to make good treatment, good cleaning, good oral hygiene in the area. Like this case with this canine, we have some kind of bleeding on probing. We don't have bone loss around the implant, but we ended up with doing a small flap, full thickness flap. I tried to be some 2 small verticals, putting the flap all the way to the apical side, and then we'll end up with more access for the patients to use their magic with their oral hygiene brushes and flossing to clean the area and eliminate any possible mechanical or bacterial way in the peri-implant mucositis. The hyperplastic gingivitis is a fiber tissue formation consisting at the contact with the prosthesis. So as you can see, we see it all the time when we have our implant prosthesis, especially underneath the pontics, where we have really a fibrous tissues getting into the place. The accumulation of the soft tissue will be aesthetically a little bit challenging, and also sometimes it's going to be a functional problem for patients, especially when they have some soreness or some sensitivity into the area. We try to avoid this usually by create enough space between the restoration and give us the the space for the pontics or the restoration itself, fabricated to avoid any pressure onto the gingiva, and to try to flip our food and our forces around the ridge instead of just heading into the gingiva. The hyperplastic gingivitis is something we see almost in all the old cases, and the design of the final restoration is really important for us to avoid any of this hyperplastic gingivitis. Maxillary sinusitis is something for the surgeons, it's a nightmare, right? Whenever we talk about sinus floor augmentation, doing some of the surgeons under the sinus, a lot of time we have patients coming back with symptoms either by soreness at the sinus area, the cheek area, swelling and pain, headache, unilateral nasal clogging symptoms. When we are talking about the sinus, it's really a unique structure in our implant dentistry practice. And having a sinus infection, whoever had this, everybody knows it's not fun to deal with it. Most of the time when we have maxillary sinusitis, when we have a chronic sinusitis, it's going to be more related to the ostium clogging or the ostium blockage from either some liquid or the bone grafting leakage from the perforation, if we had any perforation in the sinus, or if we have any foreign bodies from particles of the bone graft to sometimes the implant sneaking inside the sinus or the fracture of the roots inside the sinus. One of the most challenging causes for the implant maxillary sinusitis is to start the implant, the sinus floor augmentation process with sinus lifting surgery with the perforation. Another cause for it is to have an active periodontal disease in the area before doing the sinus surgery. So treatment of the maxillary sinusitis, usually we try to go with some more conservative way of doing antibiotic and observation, see exactly what's the reaction of the patient for our treatment. Most of the time we need to go back and do some implant removal, remove everything from inside the sinus if we had bone graft, if we had membranes, and a lot of time we'll end up with doing some curettage to the sinus schneiderian membrane inside the sinus. And again, a lot of time doing internal or external sinus elevation through the window or even through the osteotomy. A lot of time we'll get up with this foggy area on the sinus, showing us we have an inflammation. We have more liquids. Obviously, in this case, we had more perforations going inside the sinus from the membrane, and we are getting more liquids inside the sinus, which will led to have more maxillary sinusitis in general. In this case, as you can see, it's a huge surgery. We need to go back, remove everything from inside the sinus, either the membrane, you can see that we have a lot of infection inside it. This is the window of the sinus. You can see that it's already getting infected. The implants were already placed. We have integration with the implant. So mainly, we want to make sure that we are cleaning the whole site together, making sure that we don't have any infection, leaving the sinus after removing the sinus membrane, leaving the sinus to repair itself, and going back later for any future surgeries in the area. But cleaning the whole membrane, Schneiderian membrane from inside the sinus, and removing all the foreign bodies, including the bone graft from inside the sinus, is one of the last steps we can do in our maxillary sinusitis surgeries. I put this as a bone resorption to a complication after implant placement, and it's different than what we're going to be discussing as peri-implantitis. Bone resorption happens regularly around implants, and sometimes we're going to end up with some resorption symptoms, some sensitivity, discomfort around the implant, probing depth, bleeding on probing, inflammation, aesthetic challenges, possible implant exposure. Sometimes we'll notice no symptoms at all. So it is something we want to just stand a little bit for a moment and discuss it with a different perspective. Whenever we have a bone loss around the implant with an infection going on, or with a lot of bleeding on probing, this is totally different than what we're discussing right now. This is more related to peri-implantitis, which we're going to be discussing more in detail down the line at the end of the lecture. What I'm talking about is more about the causes for horizontal bone resorption, vertical flat bone resorption, which will end up with probably with 0.5 millimeter a year around the implant. The causes for this is either bone exposure after the surgery if we did not plan our flap design and our reflection of the flap correctly. The overheating of the drilling, this is why we talk every time about the importance of the irrigation when we place our implants. Excessive torque when we are placing our implant, not enough initial bone volume, unplanned occlusal forces when we are finalizing our restorations. Smoking is a big portion of the bone resorption as well. The treatments for the bone resorption, when we can see it, if we have vertical defects, we want to treat it as a peri-implantitis. Either we're going to do some osteoplasty, regeneration methods. This is we're going to be discussing in details and down the line of this lecture. The horizontal defects, we usually try to treat it with bone regeneration methods, trying to support the implant more and in a more position. One of the very, very important topics or points to mention is if we started to see more bone loss going around the implant after placing our restoration, that will indicate several points. Either we have some peri-implantitis causes, we have some cement retained underneath the restoration. If it is cement retained, lateral occlusal loading, restorative adaptation is not correct. So we need to spend more time understanding what's the reason for this bone loss, not only about the surgical technique that we use, but also about the restoration connection between the implant and the abutment and the restoration around it. Bone resorption at the buccal of functional implant, like in this case. This patient came to me. This implant was placed back in the 1990s. Beautiful implant, functioning fine. The patient is satisfied, but she started to notice a little bit of a sensitivity when she is eating the last couple of years, and eventually you could see that we have some probing depth going on. On the CT scan study, the implant is integrated, but we have huge bone resorption at the buccal area. This is not uncommon cases to see in the front maxillary area and the aesthetic zone. So we see a lot of bone remodeling, bone resorption at the anterior area. The plan that I had is just, as I mentioned, we need to have some bone regeneration, guided bone regeneration. Exposing the area, you can see that the implant surface is exposed. We have some bone resorption, the threads of the implant already outside of the side of the bone, and there's no signs of infection. There's no peri-implantitis process going on. It's only some bone remodeling going around the implant. Probably this implant was placed as an immediate implant, and we did not have any bone graft at the buccal aspect of the implant. So the best action is to go ahead and try to deal with the side of the implant to re-augment the area. I usually, whenever I try to grow bone, I follow the concept of decortication to make sure we have enough blood supply and enough stability for our bone graft. In this case, I chose to go straight forward with some kind of FDBA allograft. I usually mix my bone graft with blood, regular blood from the area, just to get a little bit more stability for the particles. Placing our bone graft and then stabilizing the graft with a resorbable collagen membrane that will help us with the guided tissue regeneration and to build the bone. Regular sutures, one of the most important things when we do bone graft is to plan our flap for a good primary closure and tension-free closure to make sure that we are containing the bone and having more stability, tenting effect around the bone graft to make sure that we don't have any losing any of this bone graft down the line. So the other
Dr. Yassin,
Yes.
I just wanted to jump in here. We're getting a lot of questions about how long today's webinar is. Yes, the webinar we've slated from 1 to 2 o'clock for the presentation, but we have some extra time so we can go later with questions up to 1:30. So for those of you that were wondering, you heard earlier that it was a 2-hour presentation. That's actually Friday's Implant Study Club. This is 1 hour, and we'll get to your questions probably towards the end, unless Dr. Yassin wanted me to interrupt him with any right now.
No, I can't take questions right now. Actually, the presentation is still long, so I'm gonna try to wrap it up as soon as possible, probably in 20-30 minutes. I plan to do it for longer, but we can take questions if you want right now.
Okay, since we have to end at 1:30, let's ask
2:30.
these questions. What kind of antibiotic for sinusitis?
Right. Well, I mean, the best thing to go with the sinusitis is to go with the azithromycin. This is my protocol to go with the sinus infections. Clindamycin works great as well. But when we have active infections, we either will go with either azithromycin or clindamycin.
Okay. How far can an implant extend into the maxillary sinus, or do you recommend always having crestal bone grafting?
Ooh, this is a very wide question. I'm going to try to summarize it. Really, it's more about how much bone available underneath the sinus, and are we going to put the implant simultaneously with the sinus floor augmentation, or are we going to do it in 2-stage? To wrap it up and to answer straightforward, if we have less than 4 millimeter of bone, probably we'll go ahead and do not more than 8 millimeter of an implant. So we need to make sure that we don't have it's mainly we don't want to, depends if we're going to do a crystal approach or we're going to do the sinus window. The simple answer for this question is, how much bone available do we have underneath the sinus? So if we have less than 2 millimeter, we have to do with window approach. And when we go with the window approach, we need to make sure that the implant has enough stability to place it simultaneously. Usually, I don't recommend anything more than 10 millimeter implant length in the posterior maxilla. So if we have only 2 millimeter, we're going to do with 2 stages. You need to know that when we have a window approach, external sinus elevation, we can go with augmentation up to 10 millimeter of augmentation. So you do the math with the crystal approach from the osteotomy. We approach this if we have 4 to 7 millimeter, where we can put the implant simultaneously and we can gain up to 5 millimeter of bone. So it's a huge question. The sinus floor augmentation is a big course by itself, but I hope that I just covered a couple of important points in this big question.
Terrific. We'll hit you with more questions towards the end.
Okay, thank you so much. Let's go back to our chronic pain. Sometimes we place our implants and we have either closer to some regular vital structures or adjacent to root damage. Infections, sometimes chronic infections will go ahead and get this area. Chronic pain, if we did not really have any treatments for this with some kind of pain medications, we will end up a lot of time with implant removal if the patient's still complaining about the chronic pain in the area. Implant mobility at the time of the 2nd stage, it's really important for us to do this pre-restorative check before cleaning the implant for the final restoration. Any mobility of the implant at the 2nd stage area would lead to implant failure, and make sure that we are removing the implant. You can test if the implant has mobility by either going manually, torque the implant. I usually torque it clockwise, or by using the ISQ machine that will give us some readings to show exactly what's the stability for the implant. It's really important for us to remember the basics when we have dense bone with a type 1 bone, or when we have type 4 bone, the healing time will go up. So when we have dense bone, the healing time could go up to 5 months. When we have really soft bone, could go up to 8 months. So we don't really need to clear implants for restorations before that. Whenever we are getting into implant mobility, we need to make the decision of implant removal. And also, we have a lot of techniques either to engage our implant mount and unscrew the implant, take it out, and replace it down the line either by bone graft or and if we don't have any infection at the area, we can place an implant, a bigger size implant at the same time. This case, we had this implant mobility at the second stage surgery, pre-restorative check, using the regular implant mount connected with the platform of the implant with internal connection, and with some kind of torque, you can unscrew the implant out and make sure that we don't have any bone damage down the line. There's a section at the end of this presentation about implant removal. I hope I can cover it. But unfortunately, when we are seeing a lot of peri-implantitis cases coming back to us in our implant practices, we need to master implant removal, and sometimes it's going to be tricky because the connection not all the time will be ideal. And a lot of time we need to remove not only the implant, but also the bone around it. In this case, after removing this implant, I try to collect more of the pre-gingival graft just to get a plug into the area, trying to create more attached gingiva keratinized tissues in the area for future implant placement. Healing abutment loosening, we see it almost all the time. The problem with this is we don't really follow the instructions when we place our healing abutments at the time of the implant placement. We need to torque it down to the manufacturer recommendations. So either the manufacturer going 20 or 30 Newton centimeter, we need to go ahead and do this. A lot of time when we do an immediate implant placement, a lot of time the discrepancy between the edges around the bony edges around the healing abutment will make it harder for the healing abutment to go down. If we have the healing abutment loosening in the early stages, it's really risky at the first couple of weeks because the implant stability will start to go down after the surgery. Personally, a lot of time I try to leave it alone, let the tissues grow, and probably come back later in 4 to 8 weeks to tighten the healing abutment in the area. So we need to remember this important chart with implant stability and know that the implant, when we put the good initial stability at the very first, the initial placement of the implant, will start to go down. Probably in 2 weeks, the implant will get to the really weakest point of stability, and then we'll start to pick up again with a more bone remodeling around the implant. A lot of time when we place our implant subcrestal or putting some bone graft around it, using either short healing abutment or a cover screw, we will end up with some bone formation over the cover screw. A lot of time we're going to go ahead either by manual scraping to take out this bone graft over the cover screw, make sure we unscrew it, and put back again our impression copings or our healing abutments if we want to proceed with it. A lot of implant systems, they have this nice small stress fine that will help us with removing this bone without damaging the implant platform. It's really something we need to be precise with doing in general. The restorative complications, also I broke it down into screw loosening and fracture, implant fracture, impressions, error, emergence profile discrepancy, lack of attached gingiva, cement impaction under the gingiva, which will lead us to the peri-implantitis. I'm going to try to really cover the whole discussion really quick. to get to the peri-implantitis portion of the lecture. The screw loosening will cause with several causes whenever we have discrepancy between the abutment and the platform connection. A lot of time with the taper gap between the screw and abutment screw loosening and fracture occurs when we have this discrepancy. A lot of time, and the manufacturer will have a fatigue in the screws. One of the causes for this is improper coupling. When we don't have really fit between the connection between the screw of the abutment and the internal connection of the implant down the line. When we do have screw loosening over our restoration, we need to assist actually the restoration itself. And remember this regular mechanical concept. Whenever we have more cantilever in the area of the restoration, you can see in this study that it shows if we have 2 millimeter more, we already got around 50 Newton centimeter on the pressure on the area of the restoration, which will make more forces on the screw, more screw loosening. When we place our implants with more angulation away from the occlusal forces, like 15 degree here with the same cantilever area, we already got almost 80 Newton centimeter forces, which will make it more susceptible for screw loosening. So we need to spend some time to make sure that our final restorations, they are taken care of. We need to avoid using different fixtures and screws from different manufacturers, and we make sure that we have confirming the adaptation between the screws, the abutments, and the restoration. This is probably in our general practice offices. We see this all the time. We have a cement retained crown that comes to our practice with some screw loosening. There is a mobility. The first thing we need to make sure that it's not the implant which is failing. My trick with this is just I put my finger on the buccal and try to move the restoration and the if there's any mobility coming up from the implant, that means the implant is failing. If it is going with some radiographic bone loss around the implant, also will give better indication for implant failure. If the mobility is only around the crown, that means that there's a screw loosening, and then we need to try to get to the area where we are getting this less adaptation. In this case, you can see that the restoration is not adapted. We already have not really great adaptation between the final restoration and the implant itself. So the best thing to go with this cement retained, which could be a pain in the neck, just try to get to the screw, and because we don't have a screw hole here in this restoration, we will try to get to the screw through drilling ourselves carefully at the back of this area. In this case, I was successful to get into the Teflon, making sure that I am accessing the screw. One of the worst nightmares, if somebody was doing this and then we ended up with damaging the screw, then we will not be able to remove the screw. So we need to be careful with this. After accessing the screw, removing the abutment and the restoration, you can see the inflammation going on and how the adaptation was not really respected at this restoration. For me, instead of going ahead and taking an impression, I decided just to go here with a chair side screw retained temporary restoration with a temporary abutment. It's a technique that usually I teach in my aesthetic zone courses. Implant is the aesthetic zone courses. Every dentist who practices implant dentistry, probably they need to be aware of this technique of doing the restoration at chair side screw retained restoration using composite, regular composite. As you can see, I took some guide impression at the very beginning, ended up with some composite building, And then after finalizing this, you'll have a screw already access into the restoration. This is the temporary that I did at the same time. And then you can mainly support the emergence profile with more access for the soft tissue. Make sure that we have this good amount of, the distance between the crestal bone and the contact point. After 6 weeks, I was able to stabilize the soft tissue, make sure we have enough, make sure that we have enough emergence profile adaptation between the restoration and the soft tissue to take the final impression. It's going to be way more easier if we have a screw retained restoration that already have like the hole for the screw. We can access this easily, remove it and screw it back again and put our composite and glue it back again there. A lot of time we will end up with some screw break inside the implant, which is restorative failure. A lot of time implants will be functional and be integrated in general. In this case, we have the healing abutment screw already broke inside this implant. We have a lot of design kits mainly to deal with keeping the implant safe and trying to drill inside the screw to remove the small portion of the screw. And we will end up with removing this portion and trying to save the implant for the restoration. Implant fracture, whenever we have fracture in the fixture, we need to go ahead and remove those implants. A lot of time the cause is either inaccurate coupling of abutment and the fixture. Thin implant is placed in a high occlusal forces area. Implant being placed in an appropriate location if we have some metal fatigue into the area and increased bending stress due to bone loss around the implant. So the implant fracture of the fixture itself could be symptomatic or asymptomatic. Mainly patients will come with either inflammation, swelling, or sensitivity into the area. We don't have any option here other than implant removal. Our goal with implant removal is to preserve as much soft and hard tissue as possible into the place. Impressions error, it occurs mainly all the time, especially when we have multiple implants. And I wanted to share this with you for the restorative dentists out there. When we do several implants, multiple implants restoration, it's really important to connect the impression copings together to make sure we are avoiding any rotation in the impression after removing the impression copings. And personally, I prefer to connect also the analogs in the model before pouring the model. In the full arch cases, I do this, try and gauge. That will help me to make sure that we have any, if we have any discrepancy, I will be able to go back and do this correction for implants, just to make sure that we don't proceed with the final restoration with an implant discrepancy. Emergence profile discrepancy is also something we see on our restorations. We need just to make sure we have, especially in the aesthetic zone area, right? We need to make sure that our restorations will give us enough space to get the regular emergence profile, considering the implant depth is already placed in the way that will give us nicer emergence profile and restoration contour. In this case, this temporary restorations for 3 units of bridge over 2 implants were already compromised. So what I went ahead and accessed the screw again through the screw access using a long screwdriver, of course, removing the restoration and then gaining better access to do my emergence profile, getting the 5 millimeter from the contact point to the crestal bone, which will give me a better access to restoring my papilla around the restoration. So doing with any restorations, we need to guide our lab technicians to make sure that we have our S-shape to get more soft tissue formation into the platform area, but the connection between the abutment and the platform of the implant itself. We ended up with getting better connection, better emergence profile, and building for the papilla around the restorations in this area. And this is the concept, the golden concept that Tarnow and colleagues, they invented, that we need to have less than 5 millimeters between the contact point and the crystal bone to be able to preserve or to create our papilla, especially in the aesthetic zone. It's really an important concept. Cement retained and screw retained restorations, we already know that we are trying our best to get more into screw retained for several reasons, because it's retrievable. We are avoiding any cement problem. And we know that the cement retained, a lot of time they need more space for the restoration, as we discussed earlier. Plus, we have the cement link with the peri-implantitis peak that we already saw down the last 10 years. The cement impaction under the gingiva is one of the really most serious complications in our implant dentistry practice. It's the #1 reason for having all this bone loss and peri-implantitis infection around it. We have a lot of studies coming out from the University of Washington about the cement impaction around the implants. This is why we're trying to avoid the cement retained restoration and go with almost regular screw retained ones to avoid any of the cements that we have. Usually I advise all my general dentist colleagues, whenever they do a cementation, take an x-ray, a radiograph, make sure that we have nothing left. Use your floss after doing this, and make sure you have everything cleaned out to avoid any possible peri-implantitis cases there. Peri-implantitis, really quick, we're gonna cover it. It's really big, huge topic. There's a lot of debate of how to treat, how to diagnose peri-implantitis. I wanna adopt in this talk really straightforward protocols for management and diagnosis. Classic ones, I don't wanna make any big deal out of that. The goal from this presentation is to understand how to diagnose it and how to deal with it. The definition of peri-implantitis, it's an inflammation surrounding the soft and hard tissue of the implants. This inflammation will be involved with progressive bone loss. As you can see, with the peri-implantitis, it's similar to the periodontitis and the regular natural teeth. That will be more infection more than only an inflammation going around it. The causes for the peri-implantitis: local factors, oral hygiene, foreign objects like the cement, periodontal health, status of the soft tissue, peri-implant pocket depth, roughness of transmucosal part, upper prosthesis connection. General factors: history of periodontitis, genetic factors, acquired disease, diabetes is the big one, and the smoking, of course. Whenever we have a biofilm, bacteria, tartar, or calculus going underneath, will help us with getting more bone loss and peri-implantitis around the implant. As I said, we have a lot of classification. One of the very simple classification for peri-implantitis, the one reported by Forum in 2012, when we have, it's an early disease if we have probing depth around 4 millimeter or 25% of the bone loss around the implant. Moderate disease if we have almost 6 millimeter and almost 25 to 50% of the bone loss. Or it's an advanced disease if we have 8 millimeter or above and 50 millimeter of bone loss around the implant. Another classification is really important to see the bony walls that we are having around the implants, and what are we going, if we have 5 bony walls, which is defect, which is more favorable, while if you have one bony wall, it's going to be a little bit more challenging for us to treat the peri-implantitis. Diagnosis, we need to follow the regular diagnosis we do in periodontitis: plaque index, gingival index, bleeding on probing depth, presence of absence of suppuration, evaluation of bone to implant contact, and see if the implant is surviving, or is it an ailing implant, or is it a failing implant. The purpose of peri-implantitis treatment: removal of inflammation, stopping the progression of the disease, if possible, regeneration of tissues around the implant. One of the basics protocol that I want to discuss really in a quick, it's the CIST, cumulative interceptive supportive therapy, that was designed or discussed by Monbely in 1998. The treatment will be, the assessment will be following the presence of dental plaque, bleeding on probing, the suppuration, and what's the probing depth inside it. We have the CIST divided into 4 protocols. The protocol A, mechanical cleaning. Protocol B is antiseptic treatment. Protocol C is antibiotic treatment, and protocol D is a surgical treatment. Probably this is one of the most important slides to discuss the peri-implantitis, and I'm going to spend a minute here just to discuss how can we do the discussion here, or how we make the decision to go with treatments. With non-surgical treatments, with the protocol A and B, we're going to go with, if we have less than 3 mm probing depth, if we have no plaque and bleeding on probing, probably we'll go only with maintenance and observation. If we have a plaque and bleeding on probing, probably we'll go with mechanical debridement and make sure that we are cleaning everything up and following the protocol A with the CIST. And as you remember, protocol A is mechanical cleaning. If we have probing depth around 4 to 5 mm, we're going to do the disinfectant therapy with protocol B, and we'll try to go with more irrigation. Surgical procedures we'll get when we have more than 6 mm of probing depth, and if we have bleeding on probing with no bone loss, probably we'll go back just to disinfectant therapy. Bleeding on probing less than 2 mm of bone loss, we're going to go with antibiotic therapy with C protocol for CIST. If we have a bleeding on probing and we have more than 4 mm of bone loss, we're going to go with surgical treatment, either by resective surgeries or by regenerative surgery. Treatment of the protocol A, mechanical cleaning, using our plastic cups, our curettes, flossing around the implant just to go over the emergence profile and make sure that we have enough access for the patients to clean, using our various range of our scalers that our hygienists know exactly about, the sickle scaler, file scaler, and most important, the implant curette that we have the regular plastic curette that will help us with the cleaning. Laser is really a big topic with the treatment, mechanical cleaning, either by erbium, AirYag, or ND-YAG, that will help with cleaning the soft tissue and doing the mechanical treatment on the implant side. Antiseptic therapy with protocol B, usually using the chlorhexidine irrigation. A lot of reports, they are trying to avoid the chlorhexidine and using only the regular saline to clean the implants area. The protocol C with antibiotic therapy, using the regular antibiotics that we use, either penicillin, augmentin, metronidazole, and clindamycin in peri-implantitis. I usually try to stick into regular penicillin or amoxicillin for peri-implantitis treatment, unless we have really huge infection going on. And the surgical treatment finally is the either implant surface treatment by detoxification or the decontamination of implant surface, implantplasty, resective surgery, regenerative surgery, and if needed, the implant removal. When we do surgical treatment, we need to have a good flap design, do our flap reflection, make sure we're cleaning our inflammation tissues in the area, using the airflow, the air polish systems with the glycine powder is really important surgical step to clean the surface of the implant after the surgical exposure. We have a lot of good design on the market to help us with going from 30 to 60 degrees. Glycine powder already supported in the literature that it has really great support for our surgical treatment and the peri-implantitis work. The surgical treatment will give us a better access for the titanium brushes or the smart scaler, the titanium scaler, to clean the implant and give a better access for our implant. One of the most important new concepts came up with the implant surface therapy is the implantplasty, where we can apply more of the power of cleaning, removing the external superficial surface of the rough surface of the titanium that we already have more bacterial infection or more effect going inside it. This kit came from Comet, has a great range of not only small burrs, but also big burrs that will help us with approaching the implant fixture without even removing the restoration. A lot of time we'll have like some kind of inflammation, bone loss going around the implant. We have good, nice adaptation around the between the restoration and the implant. We will be able to remove our inflammation tissues, approach the implant surface with this kind of implantplasty kit that will help with smoothing the surface, giving better chance to cleaning the area and giving better adaptation between the soft tissue and the implant surface itself, which will at least stop the progression of the peri-implantitis after putting the flap back again and having good restoration and good adaptation between the soft tissue and the implant itself. The resective surgery is similar to the osteosurgery. If we have, especially in the posterior area, if we have really vertical, horizontal bone loss and our hygienist is really unable to clean around the implant, we want to take the decision of opening a big flap and make sure that we're removing the bone, trying to flatten the vertical bone loss around the implant into more flat. And finally, bone grafting around the implant is really challenging. If we were able and successful to do the decontamination of the surface of the implant, we will be able to build more bone around the implant down the line. But it's really challenging. We need to make sure that we have at least 2 to 3 walls of a defect to be able to place the implant. A lot of time using some of the titanium mesh to rebuild bone around the implant is the best way to go. From my experience, it's very challenging to grow bone around the implant unless we are 100% sure that we have decontaminated the whole implant there. Finally, the implant removal. It's not an easy topic. It's when we have the failure implant, disintegration of that implant with some symptoms like gingival bleeding, pain, restoration, mobility, probing depth around the implant, bone loss, and radiographic signs. Any failure could be related to early loading before osseointegration, inflammation around the implant, occlusal forces going on, infectious sources going around the implant. And, you know, when we have a disintegration, it's easier to think about removing the implant because a lot of time it's going to be just unscrewing the implant, take it out if it is a screw-shaped implant. Also, if if we have any a connection between the failing implant and the vital structure like the sinus here, we need to treat those kind of cases carefully with possible primary sinus closure if we are removing the implant. A lot of time when we are oversizing our implant in the sites like this 5mm implant placed in a premolar area, we will start to lose this connection between the bone and the implant. Finally, if we have some previously existing periapical lesions, placing the implant without really cleaning everything will lead into disintegration or the failure of the implant. A cluster phenomenon is really rare. It's a rare condition that I saw probably once in my 20 years practicing dentistry. It's several implant failure in same patients. Most of the time, genetic or systemic factors are considered to be important. It was reported in 2001 that the heavy smoking, bruxism is really important factors, and having this implant failure, you see a patient that whenever you put an implant, restore it, there's keep going with implant failure again and again. A lot of time nowadays we are trying to avoid titanium implants for this kind of patients, going to more zirconium implants. There's only a couple of studies with the cluster phenomenon cases that they're showing a good condition with zirconium implants. For the implant removal, we have the diagnosis for this. We have radiographic findings. We need to see if there is bone loss around the implant, more than half of the length of the implant, infection signs, integrated versus failing implant. It's a big, important way to discuss. Implant is functioning but has restorative failure as another way to remove this implant. Fractured implant is also an indication for implant removal if we want to do the removal. So either by we remove our implants with several situations: non-restorable placement, non-functional, anesthetic placement, bone loss with disintegration or failure implant, implant body fracture, or restoration fracture. So it's not only about peri-implantitis or bone loss or non-restorable, non-treatable implants, but also if we have sometimes restoration failure or screw failure inside the implant, we need to remove it. Implant removal methods. We have 3 different implant removal methods. One, untorque or unscrew the implant in case of disintegration, bone loss with more than half of the implant length. The platform or the hex connection with the implant mount is intact, so we can connect something with the implant. Fracture of the screw, damage at the internal connection level, we can also take the implant out. Use the universal implant removal kit is the second option of implant removal, either by screw removal in case of screw fracture, engaged with the internal connection of the implant, high torque application that will save us a lot of bone damage around the implant. And the final option to remove the implant is doing the destruction for the bone surrounding the implant, especially if it is integrated through a trephine or a burr and elevator. In case of full integration of the implant, restorative failure, if we have fracture in the screws, impossible to engage the implant and removable pieces, no adjacent vital structures. And the implant removal mount is the best way to go if we were able to connect with the platform of the implant or the internal connection with the implant mount, do some torque to unscrew the implant out. That will be the best way to go. Removal of the fixture using implant removal kits. We have a lot of universal implant removal kits that will help us with engaging with the internal connection inside the implant and get the threads to unscrew the implant, especially if we don't have the huge integration between the implant and the surrounding bone. We'll save as much bone as we can. Applying of the hard torque is the way to go. It's really technique sensitive, so before using it, we need to be practicing and knowing about this technique. And finally, which is the last thing we want to consider, is removing the implant with the trephine drill, which will include removing some of the bone surrounding the implant. It's really challenging to do this if we are around vital structures. Sometimes, like this case, if we have implant fracture, we can't really get into any connection or anything to connect to the internal connection of the implant. we have only one option, is just to remove the implant with as minimum as possible with the bone surrounding it to remove the fixture and be as safe as possible. So, so this is the different techniques for implant removal. We would love to go with any connection with an implant and unscrew the implant out. And the last thing we want to do is to do the tray fine drill and remove the bone surrounding the implant. I hope that I covered everything. Thank you, Dr. Hess. I know
we are
that
out of time, but I'm going to hit you with a couple of questions here really quickly. I'm sorry we couldn't get to all of them. Everybody that's been typing questions in, we've been trying to answer them. If you are trying to graft around an implant that has exposed threads, what is your protocol for preparing the contaminated surface?
Right. So first of all, we need to do some rinsing. I usually rinse with saline. This is the first step. And then after this, I do the air polishing with the glycine powder, just to make sure that everything is clean. And I apply citric acid on the surface of the implant before putting my bone graft. Usually I use tetracycline as an antibiotic around the area, try to put the bone graft with that antibiotic. It's very challenging to grow bone around the implant. This is why I try to clean as much as I can and decontaminate in the area. The implantplasty with the implant kit that I showed from Comet is good to decontaminate the implant, the surface of the implant, and make the detoxification, but also it's going to be more machine surface, so we are losing all the rough surface around the implant. We will get good possibility of regeneration on the soft tissue regeneration around the area there as well.
Okay. I am reading and hearing a lot that we should not probe around the implant the way we do with teeth regularly. What's your opinion?
It's a very tough question. Personally, I probe around the implant. We need to, I avoid probing around the implants for the first 6 months after the implant placement and restoration delivery. But when I do the maintenance for implants that's been placed for more than 6 months to 1 year, I encourage my hygienists just to do their probing with the plastic probe, just to make sure that we are diagnosing any possible bone loss or probing depth around the implant and catching any possible peri-implantitis or disease early is way better than pushing it to later stages. So I'm, there's two camps with this. I am somebody who is more leaning toward just diagnosing the problem beforehand, and so I encourage doing the probing with the plastic probe.
Are autoimmune diseases such as lupus and MS contraindications for implants? Is fibromyalgia a concern?
Well, it's not an absolute contraindication, but we have the patients, they need to know that it's a higher, slower success rate for implants in general when they have autoimmune and immune disease with patients. I had a couple of patients that they had autoimmune disease, and they have successful implants and functional implants in place. But, in the literature, we know that we have less success rate with patients with autoimmune diseases.
Somebody asks, I thought an implant-to-implant bridge was contraindicated.
The question is connecting implant to another implant?
In a bridge.
Yes, I mean, it's no. This is something we use in our implant practice. We try to avoid connecting implant to a natural teeth, but we can connect implant to an implant, especially when we have good study for final restoration. We don't really need to put like 5 units bridge on 2 implants, but we can do 3 units bridge on 2 implants, up to 4 units bridge on 2 implants on the anterior area. So yeah, I hope that answers your question.
Do we still expect 1 to 1.5 millimeters of bone loss at the threads, as was expected years ago with some implant manufacturers?
Yes, this still exists, actually. We have around yearly 0.3 to 0.5 millimeter bone remodeling around the implants. We got less bone remodeling when we got more this concept that I discussed about the platform switching, which will change the connection between the abutment and the implant platform. That will make less bone remodeling. We are seeing some surfaces coming from different dental implant companies, like laser lock technique from BioHorizon. They are getting less bone remodeling into the crestal bone. But the answer for your question is yes. We don't expect to have zero bone remodeling or bone loss, but we are trying to, 1, minimize it, and 2, try to contain it so it stops at one point. What we see with the advanced technologies, with the platform switching and different surfaces around the implants, that we are getting more stable bone crest after a couple of years of implant placement.
Okay, and last question for our hygienists, is using a standard Cavitron tip okay around an implant? If not, what attachment do you recommend?
No, we have our plastic attachment getting into the final scaler or the Cavitron tip that will help us with approaching the implant surface without really damaging the outside, the superficial surface. So there's also some titanium tips of the Cavitron that will help us with minimize the possible damage around the implant surface. So the regular Cavitron tip is not an indication to be used around the implant. We need either to get into a plastic to cover it, or if we don't have plastic, at least use a titanium tip for implant cleaning.
All righty. Well, thank you very much, Dr. Yassin. And for those of you that didn't get enough, and this is a big topic, this Friday, you can join Dr. Yassin and his guest again from 12 to 2 o'clock p.m. So if you had a burning question we didn't get to, maybe we'll slot a little bit time in there for some more peri-implantitis. For
Perfect.
those of you that would like to watch some more CE today at 3 o'clock, we have Dr. Ralph Schuler. So coming right up. So take a break, get back online with us here, and you'll be able to log in about 10, 15 minutes. Thank you again, Dr. Yassin.
Thank you, Dr. Hess, and thank you everybody for your participation today. Looking forward to if you have any questions on Friday, we will be for 2 hours. We'll be discussing more clinical cases. Today is a big topic. I tried to summarize as much as I can. I'm glad that I covered everything in my lecture. It was almost like 200 slides. So feel free to reach out to me either by email, or if you want to join us in our implant study club. Weekly, we are joining for 2 hours, more clinical cases. And thank you, Dr. Hess, and thank you, Washington Academy of General Dentistry, for putting all this great work together.
Thank you, Dr. Yassin.
Thank you.